Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome to the webinar today, facilitated by the National Alzheimer's and Dementia Resource Center, formerly the National Resource Center, which consists of our team at RTI International. I'm Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI grant projects and others in the Aging Network. Please note that the webinar today is being recorded and the PowerPoint presentations will be sent to all of you after the webinar. At this time, I'd like to turn it over to Erin Long from the Administration on Aging, Administration for Community Living to provide a brief welcome.
Hi everyone, my name is Erin Long. I'm the project officer for all of ACL's Alzheimer's disease and related dementia programs. I want to thank you for taking the time out of your day to join us and learn more about behavioral symptom management. I'm sure we will have a very informative session. I would like to encourage you that if you do have feedback on this webinar, that you feel free to contact me by email. My email address is erin, ERIN.long, L-O-N-G, @acl.hhs.gov. And that's about it. Thank you so much for being with us, and back to you, Teri.
Thanks, Erin. Today we're going to hear from Linda, Teri, and Jennifer Mead. Linda Teri is a professor at the School of Nursing at the University of Washington and is director of the Northwest Research Group on Aging. Dr. Teri has been principal investigator or co-investigator on over 50 NIH-funded grants and 250 published papers focusing on understanding the relationship between behavioral problems, functioning cognition, and improving care of persons with dementia. Most recently, as director of the Northwest Roybal Center on Translational Research, she's been investigating how best to move evidence-based programs into the community through strong interdisciplinary and interagency partnerships. We also have Jennifer Mead with us today, who is the Healthy Aging Coordinator for the Oregon Department of Human Services, Aging and People with Disabilities. In this role, she works with aging and public health officials on projects aimed at linking aging and increasing health promotion and disease prevention strategies that include older adults. Jennifer received her master's in public health from the University of Michigan. Prior to coming to Oregon, she worked in southeastern Virginia as program director for the Alzheimer's Association and was in the Peace Corps in West Africa. We welcome and thank them for their presentations today. We will allow time for questions through the webinar's chat feature at the conclusion of their presentations. At this time, I'll turn it over to Linda Teri. Linda?
We're waiting on getting Linda on the line. If you could just bear with us just for 1 second. Linda, your phone line might be muted. You might want to go ahead and unmute your line. Please bear with us just for 1 minute while we get Linda back on the line and get her audio up and running.
Hello, can you all hear me now?
Yes, we can. Thank you, Linda. Why don't you go ahead? Thanks so much.
Okay, certainly. I apologize, everybody. This is kind of technology at its worst when I'm involved. So anyway, thank you all. I wanted to thank Sari and Erin for allowing me to present and giving me this opportunity to talk with all of you. I also am excited to hear your questions at the end. That being said, I will talk quickly because I know that the clock is ticking. I'm going to begin today by talking on why do we worry about family care. Those of you that are clinicians in the audience know the answer. It's because families provide the predominant amount of care for our older adults that have dementia. Talk about why focus on behavioral problems. And then I'm going to present to you some data on the Seattle protocols, which are a series of studies that we've conducted at the University of Washington with the specific goal of seeing if we could improve care through working with community agencies. And then I will ask Jennifer to present on her experiences working with the program in Oregon. So why address families with dementia? As I already mentioned, you already know Alzheimer's disease affects the largest segment of our older adults. And as people age, they are more at risk for Alzheimer's disease. We have families quite involved. Last but not least, behavioral problems are the most common reason that families and staff have difficulties providing quality care, as well as often the reason families end up discussing institutionalization because they can't cope with the problems, or institutionalized staff require more restrictive environments because of the behavioral problems. And of course, it affects everybody. It affects the person with dementia as well as the staff as well as the family. So a number of problems, it categorized 3 areas of most interest to caregivers: depression, disruption, and memory-related problems. What you see here on this slide is the number of people that were affected by these kinds of problems. And I don't know if I have a pointer. Hopefully you can see that. Anxiety and depression were the highest, 69% and 58% respectively. These were 201 caregiver and persons with dementia who came to a clinic, quite some time ago, 1992. Disruption was arguing, waking the caregiver up, and the relationship between the caregiver's response, their own depression, and the patient's depression was quite high, as you can see here. So we were able to establish some data to support our clinical opinion that these were major problems people were dealing with. What you see here is, again, more support. Those patients with very mild problems had fewer cognitive problems. Those with severe cognitive problems had more behavioral problems. So again, it just gave us some ammunition and support for what we were seeing in clinics and what I was being told by my community colleagues. So what do we know? We know they're very common. We know they're extremely frequent. When they happen, they don't happen on a monthly basis. They often happen on a daily basis, and they adversely affect the quality of life. This little guy, I think, just demonstrates the issues that we deal with every day as we try to care for our patients with dementia. He's got a broken leg. We know that he's got a dementing illness, but this ball and chain adversely affects his ability to have any kind of quality of life. And we can chip away at this ball and chain. We may not be able to improve or reduce his cognitive impairment, but we can certainly improve his quality of life, as well as the issues that we are trying to deal with as he's receiving good care, as he's trying to have some ability to be as independent as humanly possible. The protocols have grown over the years. This slide gives you a sense of the kinds of things we addressed: depression, agitation, physical inactivity, STAR and STAR-C is what you're going to hear about today. STAR is an assisted living program. STAR-C is the consultant program that Jennifer will be talking about. So the reason I show this slide is for you to see the depth and the range of problems that we have tried to deal with as we work with patients with Alzheimer's disease. And to realize that these are those excess disabilities that can be chipped away, whatever process you decide to employ to work with the patients. So we began in a clinic setting, we rapidly evolved into a community-based setting, and we looked to see whether we could take our programs that were focused on people with dementia, address it on an individual basis, address it in a group basis, and address it by involving the caregivers most directly. And the reason, of course, is because caregivers know what's happening with patients with Alzheimer's, with people with Alzheimer's, and they have the best information and they have the most ability to change day-to-day function. So our protocols, they're theoretically based on social learning and gerontology, person-environment fit. They're clinically developed. I must admit they are now over 3 decades of clinical experience, and most of what you're going to hear about today began as randomized controlled clinical trials, because it wasn't until we were able to show these programs were effective in a controlled environment that we felt comfortable asking our community partners to try them in their. So the protocols are based on partnership, first and foremost, agencies, between staff, between the person with dementia, between the caregiver. So it really is a large party, if you will, of everyone with a common goal. Clinical competence is essential. The program that we talked about today are all standardized yet individualized. They involve skill building, communication, pleasant events, and I'm going to focus specifically on ABCs of behavior change because that's what I was asked to address. So what you have in front of you now is our ABC card. That card is central to our program. We train staff and family members to complete the card, and I hope it's large enough on your screen that you can appreciate the level of detail. A is the activator. It's what happens just before the behavior. B is the behavior, what it is you're trying to deal with, trying to improve, trying to reduce, and C is a consequence. And what you'll see in this box here is the specifics of who, what, where, and when. By getting that level of information, we're often able to figure out what we can do to change the problem, get active, and improve the problems we're trying to improve. These kind of who, what, where, and when sound very obvious for really experienced clinicians. It's what you're used to looking for. For newer clinicians or clinicians who are not oriented to a behavioral approach, this can be tricky, but it is eminently learnable, and it is something that has amazingly good success as people begin to employ it more and more. So what you're going to hear about today is STAR-C. We use a systematic approach. We have a manual with session-by-session instructions. Our goal here is to make it as easy as possible for you to use this and as reasonable as possible for you to modify it as needed for your particular setting while also keeping the core fundamental values of our program. There are handouts, tracking forms, reading materials for you as the potential trainer as well as for the family members. And there is a video program that illustrates the concepts and the application. Our goal is to help people who work with those with dementia to see that they really do have power and they have an ability to improve lives. They learn the strategies, they learn how to problem solve potential problems, and we attempt to support them as they work through this. So for the first study, for the randomized trial, the clients were those you probably see in your practice. They were diagnosed with dementia, they were ambulatory for the most part, and they were in the community. They were community dwellers, so they were living with their family caregivers. The community trainers were experienced clinicians who had worked in dementia care prior to working with us, but they had not implemented our program, so that was what was new for them. As I mentioned, we began with a randomized controlled clinical trial. It was relatively small, 95 family caregiver dyads. They received Star C, or they were randomly assigned to routine medical care, because at the time we wanted to show that what we have to offer was better than what they were getting at the time. It was 8 weekly sessions. It was in the home. The providers go to their home, and Jennifer, I know, is going to be talking to you a bit about that, plus monthly phone calls afterward to sustain the improvements they achieved, as well as to give them guidance and support as the disease progressed. Because we are helping with the behavioral problems, we are not curing the disease, unfortunately. We had assessments conducted at baseline 2 and 6 months. Interviewers blind to treatment conditions, and what you see here are the outcomes. Very exciting to us, an improvement in the target behaviors during treatment, improvements, reductions in caregiver depression. This is our intervention, and interestingly, this is the control group, so what you see here is an actual increase in caregiver depression. And again, there's a logic to this that you will see as if people don't get appropriate skill training, if people don't get appropriate abilities to manage these problems, the caregiver's own level of depression is going to increase. Similarly, their level of burden increases, but those participating in our program, their level of burden decreased. Same process with quality of life. Improvements, flat line here. This decrease you see here is 6 months out and most likely a function of disease progression. I'm going to skip this. This is another study, and I think in the interest of time I will pass it by, but I want to mention to you that this is another program with the same results, essentially. An improvement in those that received our training, STAR, and a worsening in those who did not. So the message I'd like to convey to you is you have to provide not only compassion support that I know that you all do, but you have to provide concrete skill building. And the ABCs and our pleasant events are one way to do that. Certainly not the only way, but absolutely an effective way. I show it here again for the same point to show you that those in our program significantly improved. And the take-home message for our dad was there was actually a decrease in institutionalization. So that's the science behind what we do. That's a little bit of the clinical care of what we do. But our goal really has always been to take it into the community once we know it works. And we now know it works, so the question then becomes, will it work for you? And we certainly hope so. We've tried to do everything we can to make it as easy as possible to implement. As I mentioned, we have videos, we have extensive manuals for the trainer, we have workbooks for the staff or for families. So everything you need to implement it is available. In the process of doing these studies, in the process of working with the community, what we sought to do was also to learn what you thought was important, what providers wanted, and we tried to be responsive and change plans accordingly. And I know Jennifer's going to talk a bit more about that, but simply what we found was we asked point blank, what do you like most about it, what don't you like, what should we work on? What most providers liked was the systematic approach to it. The fact that the skills were reasonable, older adults especially responded well to them, and they included realistic expectations. What can you expect if the person you're caring for has a severe dementia? What can you expect if they have a mild dementia? What kinds of things can you do that will work? Communication. how best to speak with somebody who has a dementing disorder, how to speak with family, how do you phrase things to be as positive but as real as possible. The ABCs that I've already mentioned, and then pleasant events, which is simply what can we find that the person with dementia can still do that they can gain some enjoyment out of. There are modules, so providers can do things in a certain order should they want to. They can also change things around depending on the needs of the person they're working with. They can remain flexible, and they have cards and support documents to help them do this. So those were some of the things that the clinicians and administrators liked. So as we continue to expand and work together with different agencies, different partners, of course, money is always an issue. So we have gotten our funding predominantly from the National Institutes on Aging for the last 10 years. There have also been community activity programs that have been launched, and the funding for that has come from ADSSP, the Area on Aging, a number of agency funding state activities, and I know Jennifer's going to talk a bit more about that. And then not least, you heard in my introduction, the Northwest Roybal Center, which is located at the School of Nursing at the University of Washington. I happen to be the director, but it is a major collaborative effort between a number of researchers and a number of agencies where our sole mission is to improve the care of older adults. So I just want to close on a note saying we are just thrilled that our programs have made some change in the quality of what older adults with dementia are experiencing. We are at various states, the slide shows you. We've had an opportunity to do a little bit of international play. And the bottom line is, what can we do to help you improve care? Because that's really what it's all about. And I think I'm under time, so I thank you all. I hope I didn't talk too fast. I was nervous about the beginning of this, and I look forward to your questions. Jennifer, it's all yours.
And just checking, Sarah, if I'm audible.
Yep, we hear you. Thanks, Jennifer, and your slides will come up in just a second.
Good, perfect. Thank you very much. Thanks. Yeah, and it's nice to follow after Linda, who did all the original research that then we had the opportunity to translate in Oregon. So I'm going to just share some of our experience implementing STAR-C in Oregon as part of a 3-year grant that started in September of 2009, funded under the Alzheimer's Disease Supportive Services Program from the Administration for Community Living. I work for the Department of Human Services, Aging and People with Disabilities, and in that role I work with our 17 area agencies on aging in the state, primarily on health issues. We work with them on a variety of issues, but that's my particular role. And prior to this funding opportunity coming along, we had talked at some length about the growing concerns about dementia and how AAAs were able to respond to people in the public that they were serving. We were aware that there was periodic funding from the Administration for Community Living available, so we began reviewing some of the existing programs that were available at the time. There were some real concerns from the AAAs about challenging behaviors that families were dealing with. They were hearing about this through their information and assistance that they provided and the family caregiver support programs that they run. A number of our area agencies on aging offer the Powerful Tools for Caregivers programs in the community, but they were feeling a need for something to specifically help families that were dealing with challenging behaviors. We wanted a program that didn't require specialists. This was particularly an issue in our rural areas where they were concerned about the ability to recruit and pay for more specialized experts in Alzheimer's, so they really wanted something that was going to be affordable long-term and that could potentially use existing staff. And so we ended up looking specifically at STAR-C. We contacted the University of Washington and got an immediate response back from them. They hadn't translated it broadly at that point, but we're working in Ohio with the RDAD program that Linda also mentioned, and we're willing to work with us to figure out how to make STAR-C work for our AAAs. So we did end up receiving funding. The state entity was the lead. We were working with 2 area agencies on aging. The map shows those areas. Multnomah County Aging, Disability, and Veteran Services serves our Portland area. It's our largest urban area. And they were going to be rural area, and their focus was on training some of their existing staff, plus a couple of private geriatric care managers that they had done some work with in the past. We were interested in having the Alzheimer's Association as an active partner, potentially having them trained to implement the program too. We have one statewide chapter here in Oregon, but they have a very small staff, and
Please hold while I confirm your passcode. Thank you. Your passcode is confirmed. When you hear the tone, you will be the 30th person to join the meeting.
Again, be clear on where we were. We had about $880,000 from the administration for the community living for the 3-year project, and then had some required matching funds, which we primarily provided in terms of in-kind support from the work of the AAAs. So in terms of implementation, there was the staffing issues. So again, this is an 8-week in-home, so 8 weekly in-home sessions followed by 4 monthly phone calls. So about a 6-month intervention from start to finish. And so the staffing that we settled on was needing a strong coordinator for each of the 2 AAAs, and then a number of consultants that were actually providing the actual intervention. The coordinator role was really critical for us, and this became I think, ended up being even more important as we went along. The coordinator for each of the AAAs did most of the outreach. They were talking with organizations about referrals. They were talking with each potentially interested participant, do screening to make sure that the intervention was going to be appropriate. They were helping field issues that came up with any of the STAR-C consultants. Ensuring that evaluation forms were sent out and returned. So they were really critical to the success of the program. And then as you can see that in Multnomah County, we ended up with 11 of the district center case managers being trained as STAR-C consultants. And for RVCOG, they had 3 of their staff case managers trained plus 2 private geriatric care managers. Also in terms of implementation, we were really wanted to build in good fidelity to the original research right from the start. University of Washington faculty were critical for this, doing the training. We built in right from the beginning audio taping of all the home visits. This caused a little anxiety initially for our case managers, but they really quickly got used to it, and it became just kind of a matter of fact. And so the initial series that each STAR-C consultant would provide was was listened to every session by the University of Washington faculty. They were providing feedback on how things were going, and then subsequent interventions, they would listen to a couple sessions out of each intervention so that there was ongoing kind of monitoring of the quality. The STAR-C consultants also tracked the topics that they provided at each session so that we could make sure that all topics were covered. We really stuck pretty closely with the way the original research had developed, or the original implementation of the program. We made only a few modifications initially. One of these was that we didn't require a diagnosis for participants. We were concerned that that was going to be a barrier, particularly in our rural areas, but in general for people who had not gotten a clear diagnosis yet. Another slight change that we made was that in the original research, the University of Washington actually had individuals going out and helping people complete the pre and post assessments. To reduce costs, we just did those by mail. And so we used pretty much the same evaluation tools. We implemented exactly the way it had been developed. Towards the very end of our funding, we piloted a shortened version, though, of the program. And again, this was part of our effort to think about sustainability and reducing costs. So the University of Washington was great with working with us to think about reducing the 8 in-home sessions down to 6 sessions, which actually ended up being 4 home sessions and 2 phone calls. So it ended up being a 6-week intervention as opposed to an 8-week intervention, but then still followed by the 4 monthly phone calls. So that was one further modification we did late in the program. In terms of outcomes, we ended up I guess I would say it took us a while to get underway. There were, as usual, contracts and an IRB process and training, but ultimately we ended up with 167 dyads that completed the intervention over the course of the 3 years. And our outcomes, we did do the pre and post and the 6-month post evaluations as had been done in the original research. At 6 months, we found that there were significant reductions in caregiver reaction to behavior problems, significant reductions in caregiver burden, and in the care receiver depression levels. And I guess I added in here, but just one thing that I think we found interesting was that we found that our participants had higher initial depression and burden levels than in the original research, which was sobering to find, but also gratifying to know that the program really was needed and that we had the potential to make a difference. The other thing I would just add in terms of outcomes is that for the staff that were trained and involved in this, this was a really positive program for them to be offering. We they continued to talk about how they felt like they were seeing real changes and success with the program. They were real strong supporters of the program and reported feeling that the program provided them with really helpful tools and a service to be able to offer in the community. So it was something that they adopted really enthusiastically. So this is a list of some of the challenges we ran into and how we tried to address them. Just again, to give you a on-the-ground sense of what this was like. Recruitment really turned out to be a bigger challenge than we'd anticipated. As I'd mentioned, we'd really identified the program based on needs that the AAAs had been experiencing. But when it came time to offer the program, we found it hard to find caregivers that were willing or interested or people that were really appropriate for the program. We ended up with people being referred or calling who it turned out didn't have dementia, had other issues going, or who were dealing with Alzheimer's but weren't really running into challenging behaviors at that point, or were on the verge of placing a person in long-term care and so not able to commit to the 8-week intervention. So there were a number of challenges. So as I'd mentioned, we did eliminate the requirement of a diagnosis of dementia to make it easier for people to get in. We ended up doing a lot more articles, paid advertisements. The coordinators did a lot of presentations to community groups about the program so that they'd be aware of it and able to refer. And the coordinators did a lot of work identifying other programs and resources to refer people to when it turned out that they were interested, but they actually weren't appropriate for STAR-C. In terms of data collection, we ended up having to do an IRB process. Although this really was a translation and our main goal was to replicate it with fidelity, we did choose to use the same pre- and post-evaluation tools, and that wasn't something that the AAAs had a lot of experience about. There was a fair amount of paperwork asking people to fill things in and return them. It wasn't really part of our AAA culture, so it just ended up taking a lot more staff time to make sure that we were trying to get as much data back as possible. And then finally, in terms of translation and sustainability, again, we were really, I think the University of Washington had worked with one site in New Mexico to offer the program prior to our adopting it, but otherwise there really hadn't been a lot of work on translation. So there was a lot of back and forth between us and the faculty at University of Washington. They were terrific, but so the training really kind of evolved from over the couple years that we were doing it. University of Washington worked on developing a certification process for the STAR-C consultants. We had a lot of conversations about training and our ability to own the program here in the state. And then we also had a lot of conversations among ourselves on how the program could be sustained long term. We worked on a cost estimate. I'll tell you a little bit more about that in the next slide. And then we really looked at other potential sources of funding. So the Family Caregiver Support Program under the Older Americans Act, also under the Older Americans Act, the Health Promotion Disease Prevention funding that AAAs receive, and the potential for reimbursement by healthcare systems. So we did really try and get a good sense of costs. I would say this was a really challenging process for all of us, me at the state and the AAAs involved. Again, not an area that we'd had a lot of experience with prior to this. And so I've included this because I always want to know what things cost, but I would just add this large grain of salt here that the results really should be viewed as giving you a rough sense of the potential costs, but with a lot of wiggle room. So we went at this two ways. We initially really looked at all the costs involved in implementation, everything including the training, the marketing and outreach, the coordinator positions, the work involved with data collection, and ended up coming up with this cost of about $4,600 per person with everything included. Towards the end, we realized that by piloting the shorter 6-week version instead of the 8-week version, and also realizing that long-term, if we were to continue to offer the program, some of that data collection probably would not be something that we would continue long-term, and there would be other pieces that wouldn't necessarily have to be part of an ongoing program. And so we did another kind of snapshot look at the cost of the program. We thought of this as the cost of doing one additional intervention if you already had everything else up in place, which we did at the time. And in that case, we came up with a much lower cost of about $1,134 per completed intervention at that stage. So I would say the actual cost is probably somewhere in between those two. But again, this was our best effort to think about what the costs of the program were. And so just ending with where we are in terms of the current status of STAR-C. So it's been about 2 years since our grant funding ended. And both areas are continuing to offer it, but on a limited basis because of not having one clear option in terms of funding. Both areas are relying on the Older Americans Act Family Caregiver Support Program to help support some of what they're doing. Again, in both cases, they had existing staff trained to offer the program, and for RVCOG, one of their 2 geriatric care managers is also continuing to offer it for a small fee in the community. And then one of our AAAs has over the past year developed a contract with one of the health systems in their area to reimburse for any of their members that are referred into the program. So they're both managing to fund it to some level, but I think still we're all still looking for ways to be able to expand back up and potentially expand to other areas. At the same time, some of the other area agencies on aging in Oregon have been able to participate with the University of Washington in piloting the RDAD, which is similar to STAR-C, but as Linda had said, it also includes a physical activity component. So that's allowed some of our other AAAs to also be involved with some of this good work. I think both from the AAA perspective and for us at the state level, we see real value in STAR-C as part of a menu of effective programs and ways to help support individuals with dementia and family caregivers in the community. It really proved itself to be effective in helping families deal with dementia and particularly challenging behaviors that are often a trigger for people no longer be able to provide that care in the home. And so we're continuing to watch for ways that we can partner with health systems or other funders to be able to continue the program on a more robust level. And I think that's it. Yeah, and we have both Linda and my contact information here, but I think are open to questions at this point.
Great, thank you so much, Jennifer. There have been a few questions about the ABC approach and STAR-C, the principles and the techniques. So I'm going to turn it over to Linda to give a little bit of information about that, and we'll move from there into the other questions. Linda?
Yes, thank you. Thank you for the opportunity. I've been seeing your comments, and you clearly would like some more specifics. So let's get specific. Josh, I asked if you could show the ABC card, if that's at all possible. While we wait for Josh to do that, basically an ABC approach is a very structured, objective approach. So let's take an example. There is a patient that is very agitated, a person with dementia who is very agitated, and the family member comes to you saying, I'm at my wit's end, I don't know what to do. So the first natural question, of course, is, well, what's happening? When you say they're agitated, what are they doing? So to try to get, if you will, a picture of the ABCs and to try to clarify as much as possible the details that would help you help them problem solve. So for this agitation, let's say it's somebody who, it begins, of course, with the family saying, I don't know, it happens all the time. And that's not uncommon, but is it really all the time? Well, it's really more at night when we're trying to get her settled down into bed. So Josh has kindly given us a card. Thank you, Josh. So you specify what the behavior is, and then you think about, well, what's happening just before? Well, I'm trying to get her ready for bed. I'm trying to give her a bath. I'm talking to her. I'm probably hurrying her a bit. So we try to help families and caregivers think about what are the precipitants, what are the triggers. And as we do that, the idea of how to change those triggers becomes more and more obvious. By clarifying this, as fundamental as it may sound, by clarifying it, oftentimes the staff or the family member themselves begin to say, well, you know, it does always happen around bath time. Well, maybe what I could do is put on the music that I know she likes, and that might settle her down a bit during bath time. So it's very, very specific. It's very fundamental to the individual. It's very individualized, and to the situation that's coming up. I hope that's helpful. I'm glad to talk some more if there are some other questions. Thanks for the opportunity, Teri.
Thanks, Linda. You know, another question came in that follows nicely is that, can you talk a little bit about the effectiveness of the protocol for families caring with persons with non-progressive dementia, like related to TBI or stroke?
Of course, yes. So you guys have just identified my most common question when I do trainings for other agencies. So the answer is twofold. The first is, if you want to be able to say that you are employing our evidence-based program, then it was only tested on persons with dementia. However, as we all know, some of the behavioral problems, some of the staff and family issues are pretty consistent across different dementias, across TBI. So yes, you can use these programs. I think they'll be very effective, but we have not tested them. So You can say you're adapting an evidence-based program, and I would be glad to help you try to do that. But it is not the same as using it the way we used it.
Thanks, Linda. Another question was about payment. Jennifer, this is for your implementation in Oregon, I believe. Did the participants have to pay for taking part in the program?
They didn't while we were offering it with the grant funding, and actually, the AAAs that are continuing to offer it are not charging at this point.
Okay, great. And then can one of you talk about the STAR-C certification? A number of people have asked how one goes about acquiring STAR-C certification.
Jennifer, I'd like to defer to you.
And this was something that evolved during the course of our working with University of Washington to do this. So the certification now is based on University of Washington providing the initial training for staff, and then consultants actually implementing the program. I'm trying to remember the exact number, but I believe that they have to do at least 2 successful complete interventions that are audio reviewed by the University of Washington staff, and then then they're considered certified and ready to go. And then annually they need to have at least 1 intervention audio reviewed again, just to make sure that they're continuing to maintain fidelity. So it's a process of working with University of Washington faculty to maintain that certification.
And if people would like to contact me, I'd be glad to give them some more information.
Great, thank you. Another question is about the setting for the training. One person asked if the program has been tried in a group setting, like an adult medical daycare, and then also or any group. Could it be presented to a group as opposed to one-on-one?
So this is Linda. To clarify, I was the person who said you can contact me for more information on the certification. I just saw the caption. I want to make clear. We have had the Ohio group has talked about doing it as a group process, and one of the people there, Heather Meny, has actually been developing the RDAD program, which, by the way, stands for Reducing Disabilities in Alzheimer's Disease. It is a program that combines the components of STAR-C as well as exercise to reduce frailty. And she has had a relatively good success. I don't think she's published it yet, but the adaptation to a group format has worked. The difference, of course, is you're not in their home, so it's less expensive for you, but it is more problematic in some way for the person who is caring for the person with dementia because they have to get to you.
Great, thank you so much. We have one question about funding sources. Would employee assistance programs be a possible funding source?
This is Jennifer. I would say it's not something that we had explored here in Oregon, although I know we do have an employee assistance program in one of our counties that covers the Powerful Tools for Caregivers program, so it's probably a good idea to consider, but it's not something that we had investigated at this point. Good idea.
Great, thank you. A question about the training manual. This is for you, Linda. Is the manual available to anyone? Is there a cost associated with it? Could you give us a little information about where people might access that?
Sure. The Roybal Center website has more information about the availability, and that is a very simple website. It is just NW-Roybal, NWROYBAL. But that being said, you're welcome to contact me. We have the manual, we have the DVDs, and we can talk to you more about how to use them. So absolutely, they're available. They're pretty much at cost. I don't recall specifically the different manuals and the cost, but we basically try to keep it so that we're just reproducing them and you're helping us do that.
And that's nwroybal.org?
Yes.
Okay, great. I put it in the closing notes there for everyone to see, along with Linda and Jennifer's contact information if any of you need to contact them after the session. Let's see, other questions that came in. One was about if there was an outside evaluation for the program. That came in toward the end, so I'm assuming that was for you, Jennifer.
No. Again, University of Washington worked with us very closely on what the evaluation tools would be in helping us analyze the data that we collected. So we did use the same various measures around caregiver burden and depression and all, but we didn't. So yeah, I guess yes and no. Yes, they were our external evaluator, but we didn't have yet another party involved in doing the evaluation. The purpose of the ADSSP evidence-based grant was really to translate the program, and so the focus was on translating something that already had a clear evidence base and evaluation behind it, so we were basing off of what University of Washington had done.
This is Linda. The Ohio group, the Alzheimer's Association in the state of Ohio, a number of their chapters have conducted RDAT, and they did have an external evaluator. They had the Benjamin Rose Institute be their evaluator, and they published some of their results. They've had very, very good results. It adds to the cost, which is part of the issue as you try to develop evaluation components.
Great, thank you. We have a few more questions that have come in. Two of them are pretty quick. Jennifer, do you know the site where STAR-C is in Arizona or Linda?
I'm afraid I don't. This is Jennifer. Linda, would you know?
I think it might be Phoenix, but I'm not 100% sure. I'd have to check my files.
Okay. And then has it been tried in an assisted living setting at all?
So the answer to that is absolutely yes. The program STAR-C actually evolved from the program that was called STAR, and STAR stands for Staff Training in Assisted Living Residences. And we have done extensive work in assisted living to train the staff to provide this kind of care. So the answer to that is absolutely yes. We've had very good results. We've published, and in fact, the VA has taken the STAR program and been adapting it to their community living centers, which is their equivalent of nursing homes and assisted living, and they've had phenomenal success.
Great, thank you. We had a series of questions come in. I'll read them out and then just remind you of them because they kind of all go together if you lose track of them. So what was recruitment like, and was there any convincing of caregivers to do the program? Was there any bias in who agreed to participate that you know of? And was there a line of challenging behaviors that were at the limit for the program?
And I guess the original research versus Oregon, I mean, I guess we both had that.
Yeah, you both could
speak to this. Yeah. In our case in Oregon, I think I'd mentioned that recruitment was challenging in terms of kind of getting the right people into the program. I don't know if convincing caregivers, it was more kind of catching caregivers at the right opportunity when they had the need for it and weren't already at their wits' end and ready to move somebody into a long-term care setting. And so kind of catching people at the right point was part of our challenge. Yeah, I guess I'm sorry, I'm trying to think through the questions. A bias in terms of who agreed to participate.
Right, and then challenging behavior.
Yeah. I don't have a sense of that. Yeah, and maybe Linda can answer it first, and that might give me some ideas. And in terms of the challenging behaviors, I'm assuming that means was there something beyond which we didn't accept people? And we followed the University of Washington's guidelines, which were said that no, basically any challenging behavior that a family member identified, we would be happy to work with. We're not able to work with people that also had a significant current mental health issue in juxtaposed with the dementia. So that was one area that we felt that our STAR-C consultants were not equipped to take on. So I think that might be the only area where we said no and tried to find alternative referrals.
The only other issue, of course, that comes up both in the community and in our trials is if there were any individuals with dementia who posed a significant risk to the caregiver or to themselves. So we were very agreeable to trying to deal with any kind of behavioral problem unless there was a clear and present danger.
Okay, great. Were there any comments you wanted to make, Linda, about recruitment in your situation with the work that you had done?
Just what I said, that the randomized controlled trials and the work that we've been doing in the community, the behavioral problems are very varied, and we haven't said, no, you can't take on a problem. I don't see any reason why you would not, except if there was something that was urgent, immediate, and they really, it's an 8-week program or a 4-week program, so people have to be able and willing to engage and work things through, and if they're in danger, then it's not appropriate for them.
Okay, great. And then I think we can just get to this one last question here is, someone asked if you think that an area agency on aging could present a conflict of interest when it comes to selecting people for the STAR-C program, since they also offer their own caregiver community-based programs to which they refer families.
Could you repeat that? I'm not quite sure I got it.
They're asking about if there would be a conflict of interest for an area agency on aging between STAR-C and the other programs they offer.
No, that's a really good question, and it's something that we've talked about quite a bit here, and I know Jennifer's talked about it in Oregon. And, not at all. I think actually these programs are very complementary to each other, although the programs, the program developers didn't sit down and all talk at a table to make sure they were compatible. Pretty much the orientation is support and skill building, and the difference in our program is that it's focused skill building and it's specific strategies to use. But they are very, very compatible. For example, Savvy Caregivers does a wonderful job of providing support unstructured. And so doing these programs together or in tandem works just fine. I know the Ohio group offers quite a few programs, and they've done them in conjunction with each other or in tandem. So I see no reason why you can't do that. I think you need to think it through, but the more we can provide the support the families and the staff need, the better off the people with dementia are going to be.
Great, thank you, Linda. Well, I want to make sure we have a second to thank our presenters again, Linda, Teri, and Jennifer Mead, for your time and effort today in presenting on your work. If you would like to contact the speakers, their email addresses are in the closing notes. And at this time, we will close out of our webinar today, and we look forward to having you all again on a future webinar. Thanks so much.
Thank you, everybody.